So this is part two of the surgery video lectures. So let's talk about pre-op. So perioperative nursing management, what perioperative means, if you think of peri, break the word down. It refers to the care of the patient before, during, and after surgery. So perioperative, we're looking at the whole thing. Now, when you look at this, it's massive. So we're going to look at pre-op right now, but we're going to be looking at assessment. Do they have latex allergies, surgical risk factors, and learning needs? As we really venture into nursing, cultural considerations are huge. Every person you engage in or deal with or talk with, you need to be considerate of their culture or their belief system. So definitely looking at different things based on the surgery. I mean, we have some faiths out there that don't believe in pork products or eating pork or consuming pork. And so you wouldn't want them to get a porcine valve, heart valve, because that's a pig valve, and they would not want that. So they're going to opt to get the mechanical valve. But if they don't understand and it's spoken in medical language to them and they're not sure what that is and they're not looking into it, as the nurse, you should be the patient advocate and explain to them what it is so that they can make the decision. Because once that valve goes in, who wants to go in and have it taken out and another one put in? That's not what's going to happen. Or it could and put the patient at risk of death. So we don't want that to happen. There's cultural taboos. And then blood transfusion. So these are things that we need to think about as we are taking care of our patients. Now, the consent for surgery is huge because if a patient can't mindfully and is competent enough to say yes, or has someone who has been appointed to make that decision legally, then we have to be very, very careful. We just don't go nilly-willy operating on people. They need to consent. So we have to have written permission signed by the patient or the guardian, or whoever holds the power of attorney must be obtained. So if the patient can't or isn't able to sign consent and they have a medical power of attorney, then that person is who will need to sign. Now, we can't just take their word for it, unfortunately. They do have to produce the legal paperwork stating that they are the power of attorney before they can sign. If it is a parent, then they would sign for anyone that's under the age of 18, unless the child is an emancipated adult, meaning that they've gone through the legal system and had the legal system claim them as an adult at the age of like 16 or 15 or whatever. So that all has to take place. But before we can honor those things, we have to see it in the legal paperwork or writing. Written consents protects the surgeon against claims of unauthorized surgery. Yeah, you don't want to go in and work on someone and they come back out and say, I never asked you to do that. This provides the patient opportunity to exercise the right for an informed consent. So we want the patient to be informed of the procedure, the risks, and the post-op, everything that's going to happen with this surgery and the reason for it. And the surgeon is who needs to provide that information, not the nurse. So if you have a patient that's going to the OR and they haven't talked to their surgeon, you need to be making a phone call and saying to the surgeon or the surgeon's office that your patient has not seen them yet and that you need that surgeon to come by and speak with the patient to get an informed consent. The surgeon will explain the procedure, as I just said, the risks and the benefits. The nurse is only to witness the patient's signature. So if you see a surgeon going in to talk to your patient, you should go in with that surgeon because you are going to be the witness that this patient heard the risks, the benefits, and the procedure from the surgeon's mouth, and verbalizes understanding or asks questions that are answered by the surgeon at that time. There never should be a point where a patient goes, I don't really know what's going on, or I don't know what's happening. But if you're in there and the surgeon goes through all of it with the patient, and the patient says, he asks the patient, do you have any questions or concerns or anything you want to ask me? And the patient says, no, I understand, I'm good with it, I want to have the surgery. Then you will sign yourself, you will witness the signature. The patient will sign, you witness it, and it's saying that the surgeon has explained all of these things to the patient. But it is so, so, so important. I cannot stress it enough that you must always check that a consent form has been signed before giving the preoperative medicine. So if they ask for anything pre-op to be given, a sedative or something to help relax them before coming down for surgery, if you don't have a consent signed and then you've medicated them, they are unable to sign that consent at that time because they are under the influence. They're considered of not a sound mind at that point. Always remember on that consent that the surgical procedure is identified on it. It is written on the consent. So it is going to say on there what they're having. If they're having a left leg removed, it needs to say a left leg, lower extremity leg, what part of the leg, amputation. It needs to be stated there. So when that patient signs that, they're under the understanding. Now, let me say this too, though. If you are in an emergency situation, you've got a person that's having a massive MI. They come rolling through the ER, thymus tissue. MI is a myocardial infarction or a heart attack. They're coming in, thymus tissue. We're here, we need to get a balloon in there, open up that vessel so they can get blood flow to the heart so the heart muscle doesn't die. That is considered emergent. That is considered, we override a handwritten consent. The consent is that the patient is rolling through in this state and that they would want or assume that we would do everything in our power to save their life. If that is the case, then you would take them on, do what needs to be done, and it's considered an emergent situation, and so that bypasses a written consent at that point. And that also is if there is a family member not present. So let's just say the gentleman rolls through and the wife is there. The wife can actually sign the consent. And if that's the case, have her sign it. But you are going full flow to get help for this patient to save their life. I hope that's clear. So always know that the patient has to be mentally competent and give consent freely and without coercion. So they can't be there confused elderly patient and the second cousin from 3 states over saying, you need to have this done, go do it. Yeah, you can do it. Or we say, sir, as the nurse, it'd be coercion that we're making them sign it for whatever reason. They're not freely signing it with the decision that they've made. Always remember, don't get the consent signed and not attach it to the chart. Make sure it is on the chart of the patient going down with the patient to the OR. That is so vitally important. So when you're doing your pre-op checklist, make sure that that consent is on the chart and signed. And don't give them the medication. Flag that in your notes. Never give pre-op medication until that consent is signed, because once that sedative or pain medication or whatever is given, they are not considered of sound mind at that point, and they cannot sign the consent. So if you don't have it, it will cancel their surgery. And let me tell you something, if you've been NPO after midnight, you're starving, you're hurting, you're ready to get down there, you need the surgery done, you're on schedule to have it done with the surgeon, and this mistake is made, Not only is the surgeon going to be angry with you, the OR staff is not going to be happy, but the patient is going to be very, very unhappy with you. So it is so, so important. So foods and fluids before surgery. It varies on what's being done and what kind of surgery. We restrict for 8 hours before surgery and nothing by mouth, nothing per mouth or NPO. So you would want a patient to be NPO prior 8 hours before surgery. The reason behind that is how food digests. If we have a patient who is having a procedure and going to be intubated, our fear is they'll aspirate, that the stomach contents will possibly come up and go into the lungs. That is a big concern. We want to keep them NPO. The other thing is let's just say we're having something done, a minor surgery or, a very quick major surgery, but we're not going to be in very long. Let's go with minor surgery, and we're doing conscious sedation with this patient. And we'll be talking about what conscious sedation is. But we're sedating the patient. We would not want them to have a big full belly of food and drink because the possibility, once again, is things could go awry and they would need to be intubated, which they could aspirate, or while they're sedated, that they're so sleepy that your airway should be protected, but let's just say by chance it's not for a skinny minute, and then they could aspirate. The whole point of this is we do not want stomach content to go into the lungs. A light meal such as toast and clear liquids or fluids may be allowed up to 6 hours before surgery. This is a physician's decision. This is a doctor's order. So don't assume based on the surgery that this is what's going to happen. If you don't have a food and fluid order that they need to be NPO after midnight, they need to be restrict everything 8 hours before the surgery. So let's say they're at noon surgery, they could get up in the 8 hours prior, have a little snack, but nothing else after that. Usually doctors will say at least something light at that point too. Clear liquids are black coffee. That doesn't mean you put the creamer in it. You put the creamer in it, I can't see through it. Clear liquids are, I can see through it at room temperature. So Jello can melt down to clear. I can see through it in room temperature. So black coffee, tea, apple juice, carbonated beverages, they can be consumed up to 3 hours before surgery in elective cases. So I'm coming in, I'm going to have something cut off, a little mole or something. Let's just say it's an elective surgery of some form. Then I can have these things 3 hours before, but clear liquids, not solid foods. Stay away from solid foods. If the patient has food on the stomach and let's say they get sick, because sometimes patients will get medicines or just the stress of being put in going to surgery, they can be nauseated, or whatever's going on with this patient can cause nausea and vomiting. We don't want them to have a full stomach, so if they throw up, there is no issue with airway. Okay? I know that's kind of vague, but remember, it's a physician's decision. But the best thing you could ever do is keep your patient NPO until you have received an order or sought out an order of what they want the patient to have. Now, one of the questions about, I want to say it was lithotripsy. If they're going to have that, that's not surgery, but they're having a procedure done. If that's the case, we wouldn't want to keep the patient NPO post that because we want to flush them, right? So we would want to flush. They might be under moderate sedation getting lithotripsy. That's what we're looking at. But once they are awake, they're fully awake, can take in food or liquids without nausea or vomiting, then that's when you want to really start to give them their foods. We don't keep them NPO. Now, if they have generalized anesthesia, if we're getting anesthesia where we're being intubated, it makes everything go to sleep. Lungs, that's why we have to put a breathing tube down. Stomach, because everything goes to sleep. Nothing's going to work during that time. So If the stomach peristalsis is what makes our GI tract work, you could put something in the stomach, but if the GI tract's not working, what's going to happen to it? You're going to throw up. So post-op is another ball game, and we'll talk more detail about that when we get there. But pre-op, we're looking at restricting for 8 hours before surgery and nothing by mouth, and that's usually for major surgeries. After midnight is what we usually say. Patient usually can eat something at dinner, maybe a light snack, right before bed. If you're up at midnight because you're worrying yourself sick, at 11:59, you wolf down a snack before the midnight hour, that is fine. When you come in, or if you're already there, it's going to be asked on the checkoff sheet, have you been NPO? How long when's the last meal you consumed? We want to know that. It's important. Once again, this slide just firms it up. We want to ask the physician for an order before giving anything by mouth in immediate preoperative period. You don't want to give them anything without an order. The purpose of the restriction is to prevent nausea, vomiting, and aspiration. Always confirm with the patient that the NP order has been needed and that they have abided by it. You want to know if they've been home and coming in for surgery. If they were told to be NPO, yes, and were you, when was your last meal? Always important to know. Usual insulin may or may not be given depending on what's going on with the patient. If the patient hasn't had one thing by mouth and their blood sugar is, you've checked a blood sugar, you would be in order to give them insulin or not. If we give the insulin, what's going to happen to their blood sugars? They're going to get lower. They're going to go down further, and they're not eating, because we know when we give insulin, what do we want to do? Give a snack at different time frames, because we're looking at half-lives and looking at when our blood sugars are going to start to lower. The chances of you giving insulin can cause this patient to be hypoglycemic. They're going to have a very low blood sugar, that where you have to probably give them sugar to bring them back up. But that is a physician's order. Make sure that you're to give insulin or not give insulin. So if they have insulin ordered for them to have daily, you need to clarify prior to surgery what the doctor wants. If a patient has not remained NPO for a prescribed period, surgery may be canceled. So if your patient comes in, they're doing outpatient, they're coming in for surgery, you ask them if they've been NPO or had nothing by mouth, and they say, no, I got up, my wife wanted me to have the best breakfast ever before I go for my surgery, and they've eaten all of that, then the surgery most likely will be canceled. But you don't make that decision. The surgeon will make that decision. So you would end up calling or paging the surgeon and letting his nurse or the surgeon himself know, or herself know, that this patient has eaten and what they have eaten, and that they will make the decision. Not us, but you have to obtain the data and the information and know that you need that prior to them going to surgery. So depending on where the surgery is, there might be a possibility they're going to be working in the GI tract. If that's the case, they might have enemas, could be ordered to clear the bowel. There's different enemas out there. The doctor will order them, but you need to be observing and assessing their bowel movements once that enema is given. If you're giving an enema, we're wanting to clear out the bowel, so if something were to happen, or if they need to visually see something in the bowel, they can. If it's full of fecal matter, they're not going to see it. Oral Go Lightly is a solution that the patient can drink, or may be ordered to drink prior to surgery. It's important that they get it in. Now, let me just say this to you. If you're giving enemas or Oral Go Lightly, they're going to be going to the bathroom, having bowel movement after bowel movement after bowel movement. It will be water eventually. If the surgeon is working in an area where they need to have it clear of fecal matter, they're going to want to know what their stools are looking like. When it's time for surgery, if they have drinking all of their Go Lightly and they've had their enemas or their laxatives or anything else that's been ordered to clear the bowel, they're going to want to know, is what they're having just pure water looking liquid, maybe a little dirty, but you will need to describe it to the surgeon. So it is not something that you assume. They go in there and, you don't have a report back if the CNA is helping you, or you haven't eyeballed it yourself. So we want them. But if they're having solid stools prior to surgery and they're trying to clear the bowel, then you need to let the surgeon know before they get down there, because they might cancel the surgery and have them continue with go lightly until their bowel is clear. If they're coming from outpatient surgery, it needs to be asked, when was their last bowel movement and what did it look like? Because we need to know. If they said, oh, I just went before I came and I'm squirting water, then you know that what's going on is good. Can you see, does it look like water? And they'll say yes, no, or yes with a little bit of bowel, like a little bit of brown stuff in it. That's okay. But we want to know that, document it, and let the OR team know, the pre-op nurse down prior to surgery, and the holding nurse, I should say, and if the surgeon comes up, to let him know. A soft or liquid diet for 3 days before surgery to decrease the contents of the bowel may be ordered. So if that's the case, we're going to start to lighten what's in, not a bunch of solid matter, so that we can clear the bowel. Have patient empty their bladder prior to sedation. So sedation does different things to the bladder. So the other thing is when you're sedated, and I hate to use this as an example, but if you've ever had a few too many drinks, a little bit intoxicated, it's hard to control the bladder at a certain point. If we're giving sedation, they're not going to be able to hold their bladder. So what we want them to do is empty the bladder before going down or before any sedation is given. The other thing we're worried about is, let's say you give sedation and the patient goes, I got to go to the bathroom. Are they going to be a fall risk at this point? Ding, ding, ding. Yes, they are. They are a huge fall risk once sedation is given. So always have them empty their bladder prior to giving any sedation, if you're giving it to it before they go down. But even if you're not giving them anything, they're on the floor, you're not giving them anything, when you get the call from the OR that they're coming to get the patient, it is a good thing to go in and go ahead and take the patient to the bathroom and let them go to the bathroom. Because once they get down there, it's difficult. It becomes a different situation. So always emptying the bladder prior to sedation is very, very important. So tubes and equipment. If you're going for surgery and you're going to wake up with a tube down, if it's a breathing tube, if you're intubated, or if it's an NG tube, a nasogastric tube, if you're going to have a Foley catheter when you wake up, you didn't have one going down, it is so important that they know this. If they're going to have a stent put in somewhere or a drain coming out somewhere, they need to know this ahead of the game. It is so much better for the patient to know than to not know, because wouldn't it be horrible to wake up and all of a sudden you've got a big tube that you feel like you're suffocating, that's breathing for you, and it's down the back of your throat, and you've got an NG tube down your nose going down into your stomach. I mean, it would be terrifying, and you would not want that to happen to you. A patient that is aware that this might happen to them, they are more apt to wake up and follow direction for you and not pull on tubes or fight or struggle or be scared. So it is so important that we tell them, if an NG tube is going to be inserted during surgery for post-op use, explain its purpose, its care, and what it'll feel like to the patient. They need to know. They're going to wake up if they've got a breathing tube. I recovered open hearts for years. If they're going to wake up with that breathing tube down, the endotracheal tube, if that's the case, they're intubated, they need to understand they're going to wake up. It's going to feel like they're suffocating, number one. They're going to feel like they're breathing through a straw. And then they've got a machine that's cycling and giving them breaths or helping them with their breaths. It's a very different feel altogether. They need to understand that. When they come back with a tube down like that, their hands are going to be tied down. They are going to be restrained, because the first thing you want to do when you come up out of that anesthesia and wake up is to, oh my God, I'm dying, I can't breathe, and you're going to pull the tube out. So their hands are tied down. They need to understand that's going to happen. They're going to feel their restraints, that it's okay. They also need to be told that they're going to hear you or another nurse telling them, it's listen to me, it's okay. My patients would go down usually, um, and they would come back to me. And so I would always say, now when you come back after surgery, because we get them fresh out of surgery, post-op open heart, when they would come back, I said, you're going to be in your room. You're going to hear my voice. You're going to hear me say, it's okay. Let's breathe. Just wake up, relax, let the machine, don't fight it. I will go through that. You're going to hear me say all those things. If by chance I'm not your nurse, just if someone, there will be a nurse here that are going to say the same words to you, and it's going to be okay. If you do what we say, you can wake up and get that breathing tube out pretty quickly. If you don't, and you fight us and you fight the tube and you do all this, then we have to sedate you again and you have to go through it until you can wake up calm breathing so we can take the tube out. Explain the function of other tubes such as drains, IV lines, if they've got IVs going or IVs have been put in during surgery. A lot of patients with major surgeries can go down and come back with Swan-Ganz catheters. We'll talk about that when we look at the heart stuff, but they can come back, they're huge, they're in the neck, they come up there, that's where they've accessed. Chest tubes, it's going to feel different. Urinary catheters, it's going to feel different. They've got these things in. The other thing they're going to do is feel the urge. When we put a Foley catheter in, what do we think? They've got a lot of people have the urge that they need to urinate. Well, they've got a tube in. It's draining urine. So they need to understand they're going to have that urgency, but not to worry, but there's a Foley catheter in, and they're not going to wet on themselves or wet the bed. It's actually draining urine. I've had patients where I've held the bag up and said, this is your Foley catheter. It's in there. This is your urine. You are going. Just relax. It's okay. Because it's a scary feeling if you feel like you need to go to the bathroom and can't go. So explain everything. Knowledge is power, guys. So now, all of that being said, you've had the doctor talk about all the things that can go wrong, all, possible death, the whole big thing, right? Scary, scary, scary. Then you've had the nurse tell you, you're going to come back and you possibly, if it's major surgeries, you're going to come back and you're probably going to have a Foley catheter, you'll have IV lines in, and you could be intubated, or you might wake up on the tube, or you might not wake up on the tube. It just depends on what's going on. So now we've said all this, you've signed your consent, you're going the next day, but let's rest and relax. Well, it's important that the patient rests as best as possible, because rest is important before surgery so the body's not compromised in meeting stresses with anesthesia and the procedure. So what we have found is patients can rest and relax somewhat, breathe through things, get to a happy place as possible prior to surgery. They will do better during surgery with anesthesia and surgery itself. If it's same day surgery, they should take the sedative at home and retire early that night before coming in, and they'll have to arise early to enter the hospital. This is where we have to talk about sedation. They can't take the sedative at home and drive themselves in that morning. They're going to need someone to drive them and be able to drive them home if they're going home, because they're going to have more sedation on board as they go to leave from this procedure. So that's always important that they understand that. Not pop the sedative and come on in. We're not having that. Same with the ER visits, just FYI, guys. If anybody's getting a sedative, no matter where you are, or a clinic, they've got to have someone drive them home. And if they're taking it prior to coming, or they've taken medicine like that prior to coming, that could be a sedative, then they need to have someone drive them for safety. Plus, they are at fall risk with sedation. I can't say it enough. So pain is huge. With whatever's going on. But if you are being cut, even small cuts, it can be painful to the patient. So discussing pain control prior to surgery is so important. So some patients can come back with PCA pumps. They come back. This is for post-operative pain. This isn't something we're going to give them prior, even though we use PCA pumps sometimes for other issues going on. But this is talking about surgery. So you need to explain to them how it works. So the way a PCA pump works is it's going to give them a dose. It's programmed by the physician. You program it as the nurse, but the physician writes the order for how much is going to be given. They are going to give an underlying dose around every hour or 2 hours. They're going to get a dose of the pain medicine. So let's say he says they're going to get 1 milligram every hour, and that is their basal rate. That is the base rate. That is what they get every hour. They're getting that. It's to control their pain. But lots of times when you have a PCA pump, there's a button for the patient to push, not the nurse, even though you want to, and not the family, even though they're going to want to. It is important that the patient pushes the button. So what happens is they will order a kind of a PRN dose, and it will be a max that they can get in an hour or every 2 hours. And what happens is if they're having pain and it's breaking through the base medicine, so they've gotten their regular hourly medicine and they're still having pretty severe pain, or they're having breakthrough pain, then they hit that button and it's going to give them that PRN dose. It's going to go ahead and give it to them. This is to control pain so that they have pain medicine on a regular basis so that they doesn't get too painful and they can't get control of it. It's also to actually prevent the patient from becoming over-sedated, because if we have to come in and give a whopping dose every 4 hours, it's going to knock them and make them go to sleep, and then they'll wake up in more pain and they have to wait for this and all that. So it is a great way to control pain. Injections of pain control, it can be ordered as needed every 3 to 4 hours, and the patient must ask for it. So now, if a patient is grimacing, they can't physically ask for it, but they're grimacing and they might need something. But I want to give you an example of something that happened to my mother. She had to have back surgery several years ago. I went down there to be with her, and she came out. She was in having post-op care in the recovery unit before she was to go to her room. I'm in the waiting room. They said they roll her out. It's time to go to the room, and they said she was in severe pain. We've given her several doses. Look at her. She is so comfortable. I look at my mom and I said, Mom, are you comfortable? Are you feeling okay? Are you hurting? And she could open her eyes barely, and she started going, oh. She was moaning in pain. She could not formulate words. She was grimacing somewhat and could hardly open her eyes. So what they had done is she was yelling out in pain, so they just kept giving her pain medicines to try to narcotics to try to control her pain control. And so she gets up to I said, how much did you give her? So they let me know how much they gave her, and they had given enough to kill an elephant. And so I said, oh, and I said, okay. So we get to the floor, and the nurse comes in to assess her, and she's still going, kind of under her voice. She can't make words. I hadn't heard her say one word at this point. And she's grimacing. She's not really making much eye contact, but she can open her eyes somewhat. Well, finally the surgeon comes by, and I said to the nurse at that point, I said, I think she's maybe over-medicated. And she said, well, she's in severe pain, and they've medicated her, and she looks pretty comfortable to me. You have to know that my eye twitched at that point. I was like, really? So the surgeon comes by, and he goes over, and he says my mom's name, and he said, how you feeling? Are you okay? And he kind of touches her on the shoulder, and she opens her eyes, and she doesn't, like that. And he goes, oh, she looks pretty comfortable. I looked at him, and I said, I'm just going to say to you this, is she has grimaced, she has been moaning, and she has not made one word since she's come out of surgery. And now I'm concerned that, did she stroke? Can she not make words, or are we over medicated here? Because I don't think her pain is under control. And about that time, she opened up her mouth and she said, hurt. And he just kind of looked at me and he said, are you hurting? And he talked to her a little bit more and she said, hurt. And so I said, what about giving her something else? Let's give her something that's not a narcotic that might help. She's got great renal function. Can we give her something to help? And so they gave her a medicine that would help, that was not a narcotic, that controlled the pain. So there you go. So if they can't ask for it, don't give it to them. Figure out what else you need to do. And let me just tell you, that is someone who didn't know what they were doing. They didn't have the experience. Oral pain medication is usually ordered every 4 to 6 hours as needed. So if a patient is hurting, you can give them, and you just need to watch the time. When we are looking at pain, we are always measuring pain based on a number scale, 0 being no pain, 10 being your worst pain. Where do you put it? If they're unable to say that and speak that, like my mother could not, then you would base it on the FLAC scale. That is the faces. Are they crying? Are they grimacing or whatever? Also, too, you need to, she's moaning. Do people go, is that a sign of I feel great? I don't think so. So, really take a look and really assess them for discomfort and pain. Explain that asking for the pain medication before the pain becomes severe is easier way to control pain. So I have an open heart patient. Their sternum is cut wide open. They are held open for hours as they're working inside, and then they have to put that rib cage, they put the sternum back together. They will wire the sternum around the sternum to hold it together. Then they go ahead and sew everything internally, and then they'll glue that skin back together. So there's definitely discomfort there. But to control pain, and every time you take a breath, of course, the sternum and the rib cage move, so they're going to feel discomfort. It is going to be, no matter what. It is better to control pain by giving pain medicine when they start to hurt, not after they've been hurting for hours. So explain to your patient, they're afraid of being hooked on pain pills. They're afraid of pain medicine and they should be. There's things out there that have shown us that it is. But if you're in pain, it needs to be controlled, or it won't be controlled, and then you're not going to breathe deeply post-op. You're not going to walk. You're not going to do all the things you need to do to recover and get back on your feet and survive the surgery. So explaining to them before surgery, all of these things are so vitally important. So skin preparation, nail polish, if they've got beautifully painted nails, it is so important that we take one finger. We don't have to take the polish off all fingers, but usually what we'll do is take it off 1 or 2 fingernails so that we can put the pulse socks on and will not pick up through the nail polish. We like it off then, because have you ever tried to get off the gel? For all you ladies and gentlemen out there that have used nail gel and you get, or the dip, let's go with that, right? Where you dip in the powder. I love that stuff. It's hard to come off. I mean, you have to soak. Have you ever noticed they put the acetone on your fingernails and put it in the gloves and you soak there while you're doing something else for a while? It takes a while to get it off. If I need a SAT reading, which is telling me their oxygenation, ASAP, as soon as possible, I need it because they're not looking good, or I want to monitor that because I am intubating them or I'm sedating them, then I definitely want that polish off. So you need to remove the nail polish prior to surgery. Makeup is removed. And also, please, if they've got permanent eyeliner or permanent lip liner or permanent eyebrows on, you don't need them trying to scrub that stuff off down there in the OR prior to going into surgery. We need to make note of that. We need to ask our patients if they have permanent makeup. That is prevalent, and my mom wouldn't care that I share this with you, but years ago, I mean, she's now in her 80s, but back when she was in her 60s and early 70s, she had permanent eyeliner done and permanent lip liner, and let me tell you, it looked great. I mean, but we need to know it, because you're not going to scrub off the tattooing of that makeup. So, you go in and they've got blistered eyes because you've been rubbing on their eyes for hours. There's an issue and a problem. So also too, and that's kind of a ha-ha because it would be pretty bad. So ask about contact lenses. This is important. They need to remove all contact lenses. That is vitally important. Because what do contact lenses do? They dry up in the eye, and you can have then cause damage to the eye trying to take those out if they have dried to the actual eye. So we don't want that to happen. They need to remove those. And also too, so that we know that they either need glasses once they're out of recovery, or that they need to have contacts that they can put back in their eyes if they're allowed to, so they can see. Because if not, they're not going to be able to see the TV, they're not going to be able to see you, they're not going to be able to read anything and all of that. So very important to know and also remove prior to surgery. So, the night before the surgery or the morning before, they're going to ask to use probably Hibiclens to cleanse. It's an antibacterial cleanser to remove microorganisms. They need to follow the directions of how it is. If your patient's in hospital, inpatient, then you will provide it for them to do if they're able. If not, you might have to do it yourself as the nurse for the patient before going. So read your directions, make sure that you're doing it accordingly, but it is not something that we skip. We are trying to prevent infection and post-op complications. On the morning of the surgery, hair removal may be removed from the operative site. We do not remove all hair. We are going to remove it from where they need to actually cut. And we do not shave. And you need to make sure that you tell your patient if they're asked to do any, or they decide they're going to do any hair removal because they're afraid that the tape's going to rip their hair out, that kind of stuff. Please explain to them that we use clippers, hair clipper removal, hair clippers. We do not use razors. We do not shave those sites. The reason why is shaving can cause little micro tears, and that can be introduce infection and different microbes into those areas that can be introduced into the surgical site. We do not want that. And for healing purposes, it can cause issues. So we remove and clip right at the level of the skin, get that hair off. We usually do it in preoperatively, but if a patient is asked to do it, they need to use clippers, not razors. And then the other thing is the reason why we want to talk about this is if these sites, this is being removed, they need to understand if they're having something removed on their head. I have a friend that had to have a skin cancer removed off of their scalp, but it was right at the top of their hairline, right on their forehead. It was right there. They had to shave that area. They had a, I shouldn't say shave, they had a hair clip that hair off that area. And so when she, got out of surgery and the bandage was removed and she could look at it, that chunk of hair was gone. And she had an incision there and she had staples there. So that all needs to be explained to the patient if they're going to wake up and part of their hair is going to be gone. And then I want to bring this to your thought process, folks. If that is the case, who do you think is really going to be affected if their hair's missing or a part of their hair is missing? Well, everybody. But what about teenagers? What do we know about growth and development and where they are? Teenagers are vain. They're worried about what they look like. They want to be accepted by their peers. This is so, so important to them. So if you have a 16-year-old that's going to have something done and hair is going to be removed from their head, they need to be aware of that so they don't wake up traumatized. And they need to wake up and know what they can do. They might be able to wear a scarf and look really cute or a hair bow, but we need to, as nurses, understand that and address that because we're there to meet all of their needs. So this is something to think about. I want you to think about it. Doesn't mean that I know of little elderly women that get their hair fixed every week. That hair is perfect. It has enough hairspray on it. If you lit a match, they're going up. And they go in and get that done, and they look great because they want to look good every day. They put their little scarf on, silk scarf on at night, and they lay down and go to sleep so their hair's not messed up. They need to know they're going to be affected by that. Different cultures. I mean, people that really spend tons of money getting their hair fixed all of the time. That is important. In the African American Black culture, I had my sister-in-laws. They would go each Saturday and get their hair done, and their children would get their hair done, and it would be hours at the beauty salon getting their hair done and they would get it done weekly or every other week, and it was very, very expensive. They spent a lot of money, and their hair looked great, but they would be just appalled to wake up and part of their hair missing off their scalp. So it's important that we explain where we're removing hair, why we're removing the hair, and what to expect when they get up. And if it's something like that with a teenager or someone that really is worried, they can wear scarves, they can wear all different things. There's so much stuff out there. Lordy, there are wigs out there, there are partial wigs out there that look real. People are putting hair clips of hair in here and there and make it happen. My friend, what she did is she parted her hair on that side, and it's probably why that scalp was exposed to the sun more. And what she did is she parted her hair, she flipped it. So she had a right-sided part and she went to the left side and she just flipped it so the hair just covered it and you couldn't even see it. Also in this pre-op teaching, we want to talk about breathing, breathing in, deep breaths, breathing out, can't pant. There's no panting. They've got to be able, if they're having surgery and they've been given general anesthesia or they've laid for a period of time or they're inactive, they're very apt to get hypostatic pneumonia. This is huge, and we do not want this. It will set the patient back, and they could be weeks in or stay on a ventilator or go back to a ventilator and we don't want that. So we want to make sure that they understand they have to deep breathe and cough, and they have to move. When you hurt, what do you want to do but guard it, right? You want to hold it tight. You don't move me, don't touch me. No. And you're barely breathing, you're shallow breathing and cough. Are you kidding me? Because that moves and hurts, right? They don't want to do it, but they have to understand pre-op teaching. That's what we need them to do. Deep breaths in, breathe in, blow out through the mouth, get a full exhalation, and then do it again. After they do it, then they can cough. Then if you can splint the incision, splint the incision. If it's the heart, they can hug a pillow against their sternum and breathe and cough and turn and move. If it's their lung or their rib on that side, they can put it up against the pillow up against there and splint it as they're breathing and coughing and moving. And then let's say it's a hip surgery. We don't want them to cross over the hip, right? We don't want them, we need to keep those hips out because the arthroplasty can pop out that hip surgery. It can pop that hip back out. If that's the case, but still it's going to hurt, you can put pillows in between, but they also can even hold something against or have a pillow up against it. My mom just had hip replacement. She's at home with it. Came right home, same day surgery these days. She would put her ice pack against it and a little pillow up against that, and it felt good because it kind of just pushed that in. And then if she had to shift a little bit, she would kind of hold it. She was splinting it, and that's a good thing. It helps with pain and discomfort. Always tell them what to expect before, during, and after surgery so they're not afraid. People are fearful, and I am too. I've been to surgery and I'm scared. I'm not going to wake up. I'm scared something bad's going to happen to me. It is an unknown. Okay, I'm stumbling. It's an unknown, and an unknown causes fear, right? So we need to tell them the more they know, the better off they are because they know what to expect and what to do. If you tell them they're going to have to deep breathe and cough, incentive spirometry needs to be set up prior to surgery. So an incentive spirometer, the way you want to do it, it's a device. We don't blow into it. It's not a blow. It's not a into that device. It's a suck. You want to suck in the air. It's like sucking in through a thick milkshake, a straw of a cookout milkshake. You can't get it through the straw. They're so thick. So you want them to put their lips around that. First, take a normal breath before they do it, blow out, then put their mouths around that, and they need to breathe in. They need to go and suck in all the air. What's happening, guys, is they're breathing in the air. It's going to pop open the alveoli because during surgery, everything goes to sleep. The lungs go to sleep. That's why we have to breathe for them. And those lungs get sticky and they'll stick together. So when you breathe in using an incentive spirometer, you're popping open that alveoli. Have them hold, breathe in as hard as they can, suck in as hard as they can, and then hold, suck in, because you're popping those alveoli open. Once those are open, let them do it 8 to 10 times. I tell them to do it if they're watching television. Every commercial, pick that thing up and do it. It's what you need to do. Every hour, they need to pick it up and breathe in that. Then when they're done with that, 8 to 10 times doing that breathing in with the incentive spirometer, they need to cough. They need to cough because you've popped open the alveoli. Now we need to move any kind of yuck, gunk, or anything that's down in those lungs up so they can get it up and out. This is going to prevent post-op pneumonia. It is so important. So that is how you do it. If they're going to cough, before they cough, give them their pillow, splint the incision, hug the pillow, hold the pillow too, and cough big. And that can't be it needs to be a big cough. So if they do you say, nope, I need a big cough, bigger than that, come on. And this is going to prevent you from getting post-op pneumonia. This is what's going to get you out of the hospital. And that is great incentive. If they're having same-day surgery, you usually have them come in the day or two before surgery or even the week before, and you can do all of this teaching at that point so that they are aware and they can work on it at home prior to coming in. So for family, this is a big thing because you're not only going to be working with the patient, you're going to be working with the families. So advise them they have to come to the hospital an hour to hour and a half before surgery. The family should be told about the usual routines, where to wait. They need to know where to go. And then also they need to know what the procedure is. So like if they're going to go wait in a waiting area here and the doctor will call and give you updates, or the OR circulating nurse, or one of the nurses will call. Someone's going to call. And they're going to let the family know where they are, what's going on. If anything's bad's happened, hopefully not, they're going to update them. And of course, let them know if anything's good. Now, when explaining this to the family, we're not going to say it that way. We're going to say, hey, we're going to take you to the waiting room. This is the surgical waiting room. You will be waiting here probably. This surgery takes about 2 to 3 hours, or it can take an hour to 2 hours, just depending. But the OR will call and give you an update about halfway through the surgery. And then once your family member is done with their surgery, they will call and let you know it is done and that they are waiting. You know, they're in recovery now, and they are working on getting them ready to go back to the floor. When it's time to go to the floor, they're going to call you again, and the surgeon will come and give you a person-to-person update, or he will call and give you another update on the phone. Lots of times surgeons will update on the phone, and the reason why is they've got 4 other cases. They're getting ready to go back in and do this again, do another surgery or something. So it's just important for them to know. They also need to know that their family member might come back on a ventilator or with a Foley catheter or have a drain, or part of their hair is going to be shaved. They need to know all that too so that they're not shocked, because it's never good for them to be shocked or crying or anything like that at bedside. And for the patient, because they're going to help the patient stay calm, they're going to help the patient get through this. They're their support system. So nothing is worse than a patient waking up and the family has this look of horror on their faces. It will scare them, and it can do some damage that's irreversible. So let's make sure the family's aware. So this is all prior. We've done this prior. This is the pre-op care prior to. Now we're in immediate pre-op care, preoperative care. It's time. They've called. It's time to go down. They're coming to get them, right? We need to have them in a clean hospital gown. They don't need to have underwear on, because if not, the OR is going to have to try to remove all that. And that's just, no underwear, just the gown. nothing else. They need their hair to be covered with a surgical paper cap unless they're working something with the head, but you put the little surgical hat, if that cap, if they have told to do that, if that is uh, the way your hospital does it. All jewelry at this time must be removed. That means all jewelry, okay, including wedding rings. Usually when you remove the jewelry, please give it to the family to secure. They need to hold on to it. It's not something to be left at bedside. If there is no family to take their jewelry, then you will need to have it locked down with security. So this is something to think about even prior to getting the call. I'd be calling if you need to lock it down and have security come up, but you need to describe everything. Remember, describing jewelry. You never want to say, oh, that's a 14 karat gold ring with a 2.4 carat diamond, because that's what the patient told you. And I don't care if you can read it. If it says 14 karat gold inside the ring, you will not describe it that way on paper. It needs to be described as the color that the metal is. If it looks like gold, yellow gold, it's yellow metal. It's a yellow metal with a clear stone. We don't know if it's a diamond. We're not jewelers, but I will say this. What is it? A zirconium or whatever stone is a lot less expensive than a diamond, a yellow diamond or a chocolate, diamond, or just a good old clear white diamond. Those are quite expensive. So we're talking thousands of dollars to thousands of dollars to hundreds of dollars to like a low $1,000. So we need to be sure that we describe it in what it looks like. If it's so you don't want to say silver necessarily, but you can say a gray toned metal. A lot of people say silver toned. You could say silver toned, not saying that it's silver itself. But be careful. Describe what it looks like based on basic colors and say stone and that kind of stuff. Stay away from like it's an amethyst or whatever. We don't know. It's a light blue stone or it's a light red, stone. Get away from rubies and all that good stuff. Jewelry and valuables should be given to the family. I just said that, or per facility policy, but don't leave it bedside ever. But it needs to come off, including wedding rings, and that's hard for people. I've never taken my wedding ring off. For 50 years, I've never taken my wedding ring off. Well, they need to come off. People can third space and swell. And it could pinch off, they could lose their finger and they won't wear the wedding ring, but we have to take all jewelry off. Also, too, if by chance anything that's electrical, it could cause a current and burn the patient. The metal could heat up and burn the patient, or if we were shocking a patient, it could cause a problem that way. So we just want to make sure all jewelry is off. Dentures should be removed and placed in a labeled cup and kept in a designated place at the hospital per policy. Guys, dentures are expensive. They don't need to go down with glasses, dentures, anything that they're not going to need to have while they're in there being operated on. And when you're in there being operated on, you need nothing. You need just the body. And it needs to have the hospital gown on and the cap on if that is what's asked of the hospital. So dentures come out, make sure they go into the cup. Don't let the patient take them out and wrap them in a washcloth or in a paper towel. You don't do it either. They need to go and be labeled and put over by the sink or whatever so they don't go to trash. That is the concern, or get lost or dropped and broken. Same with glasses. Make sure they're taken off and left it on the bedside table and put back into a glass holder if they have them. They have different things to put your glasses in to protect them if that's the case, but make sure that they're there. Now, if family is there, I hand the glasses, not the dentures, but the glasses and the jewelry I'll give to the family. If there are hearing aids, take those out. And I always give those to the family. That's another expense, and they are made for that patient. If glasses and hearing aids are left or taken out, it's on the it should be noted on the preoperative checklist, and you need to tell the nurse that you're giving report that they wear hearing aids. They're hard of hearing, and the hearing aid's now out. They can't hear, or they hear better in the right ear instead of the left ear. If they wear glasses and they've been taken off, you can say on there, glasses at bedside. They know then that they can't see. They might not be able to see to sign or see to read something. So they need to beware. They might even say, no, the doctor wants them to have their glasses. But but by rule of thumb, glasses, dentures, hearing aids, out, off, secured accordingly. All jewelry off, including wedding rings. Also, too, the procedure site will be verified and marked on the patient before transport to surgery or in the pre-op holding area. Most of the time in-house, this is done in the pre-op holding area, but it might be done at bedside with the surgeon. But what happens is the surgeon's going to mark the spot. The reason behind this, guys, is patients have gone back and have it's supposed to be the right leg removed, and they marked the left leg by accident, and they took the good leg off and not the bad leg, and now they have to go back and get the bad leg taken back off, and now they have no legs. It has happened, guys, and it's just happened again recently. I read an article on it that somebody had an arm removed or something. It was the wrong arm. And I thought to myself, how? Because we have set up ways of preventing that. It's called timeouts. So before anything starts, the patient's down there ready to go, or they're in the pre-op, they've marked the area, but we have a timeout before surgery actually starts. They're on the table. And what happens is it's red. The history's red. What's going on is red. What's going to take place, we are removing the right leg. The site is marked. The surgeon is to agree with that. Everybody looks at the leg. We see it that it's marked. That's how we catch it and say, no, time out. Wait a minute. This isn't right. This isn't right. It's not supposed to be the right leg. It's supposed to be the left leg. That's why we read out the history or the order of what's going on, so we know that we are correct. Very, 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 very important. You're not asked to mark the site. It should be marked by the surgeon. So you have a pre-op checklist. It's going to go down. Go down it, and you're going to check. It needs to be all checked off. And then once you are done with that checklist, you're going to want to you're going to be asked to probably sign that checklist. You are stating that these things have been done. And lots of times, if it's a surgery and they're going to possibly need blood, they have to be typed and crossed for 2 units. And so you will have the blood band on them. It's there, and that's on. And you can put the little sticker on their checklist too, so that it's seen. So you want to include ID stickers need to be printed off, the consents on the chart. You go down, check, belongings, contacts, glasses, hearing aids, you circle it, dentures. It has a prep check off. Pre-op teaching done. We know what we need to teach, so that's all been done. Final verification, correct patient. How do we know if it's the correct patient? We look at their armband. We have them tell us, can you please state your name and date of birth? They're going to hear that a million times that day, and that's okay, because I want them to know I am Kristen and I am not Jennifer. It is important, okay? That they know that it's the correct procedure. You will say it to them. The OR nurses will say it to them, but you want to say you are going to have, and you're going to hear them say it. You do know what procedure are you going to have today. They're going to ask them to tell them. And then the patient should be able to say, and then they can state back, which arm, is it your right or left, which leg, whatever, if they want more clarification. Make sure it's right or left, whatever side, whatever appendage, whatever, part. And then also making sure once they're down there that they're in the right place, position, and everything when they're in the OR room itself. So this is so important. Attend to all items on the pre-op checklist, and you can do this ahead of the game. When you walk in, somebody's going to surgery and they're not going to go till 10. If something happens and the surgery's canceled, they might go early. So you got to think these things out. You want to go ahead and get that. I always ask, if I've got a patient going to surgery and it's the morning I've come in and taken report and they're on for in the morning, I'm always like, is the consent signed? Is the patient typed and crossed for 2 units? I want to know. And the nurse giving you reports to say, yes, here, and they should be able to flip to the chart or pull it up on the chart if it's on the computer, and you should physically be able to see it in their chart, that it's signed, and also the type and cross. You'll see that, and the consent for blood transfusion. Those things have to happen. Ding, ding, ding. Those things have to happen if that's what kind of surgery they're having and it's needed. So pre-op medicines reduce anxiety, of course. They can be given to decrease secretion of mucus and other body fluids. We can dry them up with it. We can give them stuff to make sure they don't get nauseated and help reduce vomiting. We want to try to prevent vomiting when anytime surgery is happening, pre, intra, and post. Enhance the effects of the anesthetic. We can give stuff that makes them feel really good, and they get down there and then they get anesthesia and life is wonderful. It's a good thing. We want to prevent falls. Once we've given a sedative, remember I talked about it a little bit earlier, remember to put your side rails up, make sure the call bell is in reach, the bed is in the low position, and remind the patient not to get up without assistance. If they have family, tell family to make sure they do not get up, and have family not assist them. They need to call out for help because they could be a little more woozy or a little more light on their feet, and the family wouldn't be aware of that, and they need someone there to help them. So the other slide slid over quickly, and I apologize for that, but pretty much you want to make sure safety with sedatives, sedating a patient, and make sure they don't fall. And I went, ooh, because it flipped over. Cultural variances in drug metabolism. Asians, particularly Chinese individuals, metabolize psychotropic drugs differently than other ethnic groups. Valium can cause greater sedation with normal doses. Atropine is also metabolized differently and can greatly accelerate the heart rate. Asian patients should be monitored closely when receiving these drugs. So this is where there's a cultural variance. Let me tell you this. This was shared by me, and the person that shared it's going to giggle when they hear this, but redheads. This person told me that all the surgery she's had, she's awakened she awakens during surgery, during the actual surgery. They have a hard time metabolizing, or they metabolize quickly anesthesia. It takes a lot to keep them down. So that's kind of interesting. So transfer to the operating room. Of course, we're going to have to get them there. Assist in transferring the patient to the stretcher when the transport person comes. You want to protect all your IV lines or any Foley catheters or drains that you might have already. Those need to go over. Make sure, because you know the person taking them down doesn't necessarily know or won't help if it, and you want to be a part of that. You're always your patient advocate. You're always protecting your patient. Compare the patient's ID bracelet name and numbers with the transport request sheets. For accuracy, you're going to fill out a transport sheet, and you want to make sure that this is all the correct patient, because they need to have the right information. If something were to happen at point A to point B, or once they get down to point B. Check the chart to make certain that everything ordered has been done, and complete your final documentation. You're getting ready to see them off. They're scared. You want to make sure, are you okay? We're here for you. You will eventually come back up to your room. Never say it's going to be okay. That can always bite you because you never know what might happen. But just be reassuring to the patient that you're there for them, and that the people that are going to take care of them down there are great, and they'll be waiting for them. So, and we'll take care of your family. They're here. We'll make sure they get to the waiting room and all that, and let the family have the moment to say goodbye. They love them or whatever, and kiss them, because sometimes things happen, guys. I worked in the critical care areas, and there's sometimes that was the last kiss or the last goodbye. And as much as we want to think they're going to come back, sometimes things don't happen the way we want. So I'm very careful about that, because that's happened to me. So we want to prepare the unit for the patient to return. Eventually, we hope they're coming back to the room, right? We want them to come back so that they can be there. Sometimes they go back to the ICUs. So you might have been on the floor, you send them down for surgery, and then when they're done, they're going to go to ICU and be monitored for a day or two post-op. But it all just depends. But lots of times people will go down for surgery, and then they're going to come back to the room. or you're working in the ICU and they're coming back. So you want to make sure that the bed is made fresh with linen. We're going to try to have everything ready and protect them from infection. We want to raise the bed to the height of the stretcher so it's ready for when they roll in. We can just get them right on over and onto the monitor in the room. Place the IV pole at the head of the bed. Make sure you've got a pole. If they've come in from outpatient or from outside to come in and have inpatient surgery, they check in, they go through surgery, and then they're admitted in. They're not going to have they didn't go down with an IV pole, or you took the IV off of the pole and put it onto the bed, the stretcher. If that's the case, always make sure you have an IV pole ready, because most likely they'll have IV solutions that need to be infused. Gather your emesis basin, tissues, frequent vital signs sheet. If you're on that, have them make sure you can jot down something if they're not in the system yet for you to do computerized charting. Intake and output also, you're going to want to make sure you're looking at all of that. Small towel and washcloth, a pen or something to write on next to the bedside or the console. I use 2-inch silk tape a lot. When I was a flight nurse, I would put it on my leg to write stuff, so I did it at bedside too. I would put a piece of tape and I can write. If there was a code, I'd do that sometimes if I couldn't access paper. But have something ready, because you're going to want to take reports. You're going to want to, from the nurse, if you haven't already, from the recovery room nurse, you've taken a report, they should call you, but sometimes they'll give it to you at bedside. And then also you want an update if a nurse is bringing this patient back. So, okay, anything else change, because sometimes what happens, like for open hearts, you'll have a practitioner or anesthesiologist comes back with them, and sometimes they'll give them medicine to get them back up, and they need to give you that update. So be ready for them. Be ready for them to come back. Don't be surprised, and always make that fresh bed so that they can get in it. And I always make sure I have plenty of towels and washcloths. And I get one of those big bath basins, because if they start to throw up, the little emesis basins don't catch it. I get it in the bath basin. It's the way to go. Also, preparing the room, make sure you have a oxygen connected and ready to go. You might not need to have the tubing, but you want to definitely at least have the flow meter connected and working. Make sure it works, it turns on and off. Suction equipment too, make sure your suction liner is in and that everything is connected. And if you have a yonker, which is what we put down if they start to get sick or we want to get secretions out of their mouth, if that's the case, make sure you turn it on and it works. You want to make sure everything's working, because if it doesn't, when they get there and you need it, you're in trouble. A thermometer, sphygmometer, that's your blood pressure cuff. Make sure, usually everything's to the monitor these days, if not, but have those things ready. Pulse ox and your stethoscope should be there so you can take a look and listen. You want to listen to the lungs, listen to the abdomen, making sure they have bowel sounds. Everything needs to wake up before we give them sips of fluids. We want to make sure that we have bowel sounds. We hear a tinkle here and there. If not, they're going to throw up. But we want to do an initial assessment, post-op assessment, as soon as they get back to the room. If they have a PCA pump, you want to make sure that you have that there ready for them, so that you can, usually it'll come up with them, but let's just say they want to switch it over, have a PCA pump waiting so you can switch over, or initiate the start of it once they get to the room, depending on the order. We want to make sure we have sequential pneumatic compression devices. Those are those lovely things we wrap around their legs and hook them and they blow up and down. It's the big word. That's the medical term for them. Know the medical term. You need to know them. Passive range of motion machine if needed. And be ready. Be ready to rock and roll, guys, because you don't want to be trying to find equipment, look for stuff, or that's not the time to do it. You're ahead of the game, not behind it. So this is a big lecture on pretty much pre-op and kind of intra-op. I want you to listen, take notes. It's important. Listen. You might need to listen to this lecture several times for my students, but this will help. This will help tremendously for you to understand. And so when you're looking at an appendectomy with the appendicitis, you're able to answer those questions of what are we doing? What do we need to look for? What am I doing for this patient? Because this is the removal. of the appendix. It's a surgical intervention.